All right, thank you guys for coming to our AIM game presentations. I'm very excited to have you all and excited to hear more about your presentations and about your projects. Let's start off by introducing ourselves. Each of you can introduce yourself, where you live, what your project is, something really brief, like we just want to kind of know who's in the room, and then we'll go person by person and actually get into your real presentation. So Coral, if you'd like to start, you're on my far left.
My name is Coral Bruss, and my presentation is based on early screenings of GDM in pregnancy.
Awesome, and where are you?
Charlotte, North Carolina.
Very good. All right, Deborah?
Unmute, yeah, okay. Debbie Arndt, and I live in Western New York, and my project is perinatal depression screening, updating our guidelines on our office so that they are in line with the ACOG guidelines.
Excellent. And Elizabeth? Oh, you're muted. Oh, actually, you're not muted. We just can't hear you. Okay, no problem. We'll just go on to Ryan.
I'm Ryan Gorman. I live in southern New Mexico, and I'm doing my project on improving throughput for low acuity patients in the emergency department.
All right, awesome. And I think you guys know me. I'm Nisa Meyer. I'm one of your course faculty, and I'm in Central Texas, but far enough from Hurricane Harvey. I'm having no issues here.
And I'm Judy Butler, and I'm one of your faculty also, and I'm in Tucson, Arizona. And no hurricanes here either.
Oh, look at that. No hurricanes in Arizona?
No rain. No, nothing.
Well, we're in a drought, so I have to be.
Yes. Yeah, I know that feeling where you sort of watch rain on TV and you think, oh, well, it doesn't look so bad. Elizabeth, we're still not hearing you, but I think what we'll do is get started on the first presentation, and then after the first presentation, if your sound is better, then we'll kind of jump back in and get your introduction.
Elizabeth, sometimes if you shut your whole computer down and then come back up, that will work. It resets it.
Okay, so who would like to start?
I can start.
Great.
So I screen share, correct?
Yes.
And I was close when I've been reviewing this, so I'm gonna time myself.
Okay, go ahead and put yourself into presentation, or put the slideshow. Perfect. That's what I was trying to say.
Is that good?
That's perfect.
Okay, my name's Coral Bruss, and this is my AIM presentation. My AIM statement is to increase early identification of patients with GDM, complicated pregnancy, and achieving right patient-centered care of pregnancy by 65% before December 15th, 2017. Do you guys hear me okay?
Yes.
Okay. The problem to be addressed is the incidence of gestational diabetes is on the rise due to higher rates of obesity and pregnancies in older women. There is an increased risk for prolonged maternal hyperglycemia, which obviously can lead to a lot of different complications, maternal and fetal complications. Preeclampsia, C-sections, and then obviously future diabetes type 2. Fetal complications, obviously shoulder dystocias and birth traumas, macrosomia after birth. But really, early identification we can identify 1/2 of women with gestational diabetes and provide early interventions in pregnancy to lower those adverse fetal and maternal outcomes. The reason for the effort is really overall is identify early insulin resistance in pregnancy in order to implement the earlier treatment and referral. Currently, there is no protocol in place at my clinic for identifying those early risk factors, early screening, such as the 1-hour oral glucose tolerance test, or implementing, I don't know why that keeps doing that, or implementing right care. Only 25% of patients with identified risk factors of GDM were screened with 1-hour glucose tolerance test. That was when I did my chart review. And really the reason for the effort is obviously to decrease those maternal and fetal complications. Expected outcomes and benefits. So from RAMP-A, providers will achieve consensus on the risk factors and really creating and streamlining, creating protocols in place. And really this is going to help us in the future creating protocols as well. Patients will engage in their care and then obviously increase their behavior modifications with motivational interviewing. And for RAMP-C, we're identifying those early risk factors of GDM, and then we're screening with a 1-hour glucose tolerance test. And then we're initiating, for RAMP-D, we're initiating the right care for patients with early abnormal screening earlier in pregnancy. So we can initiate that earlier in pregnancy. So RAMP-A, the process would be team meetings. We're trying to increase attendance, and we're trying to enhance and increase that team consensus on identifying risk factors, the screening guidelines, and obviously the right care measures. And the outcome would be to increase the mean team consensus score on management by 5 out of 7 providers before December 15th, 2017. RAMP-D, with the process would be shared decision-making tool for every new OB patient. And the outcome would increase number of patients who state self-management goals by 75% before December 15th, 2017, obviously using that shared decision-making tool. RAMP-C, we're implementing early 1-hour glucose tolerance tests, oral glucose tolerance tests for patients with identified risk factors. And the outcome would to be increase in risk factors identified in 1-hour glucose tolerance tests, early screening by 70% before December 15, 2017. And then RAMP-D, process would be to create that logbook for high-risk patients and refer to a dietitian / treatment with focus on that right care. Outcome would be to increase mean right score by 80% before December 15, 2017 by implementing referral and treatment and obtaining that right care. Balancing measures. So there's several balancing measures. The number of hours spent per week on project and chart reviews. Obviously, the increased amount of time that nurses are spending receiving that history. Obviously, the provider time as well, the amount of paperwork for patients. We've already have a bunch of the new OB. And then increased amount of time and resources for additional follow-up and clinical time in that logbook. So the RAMP changes would be the team meeting. We're going to meet bi-weekly. First meeting is going to be consensus on all of our tools and screening factors, educating this next one with protocols and the rest of the staff. And then obviously the third meeting I was thinking might focus on communication. B, we're going to implement that shared decision-making tool. And C, early identified risk factors and 1-hour glucose tolerance tests, and initiate right care. So barriers would be staff might not come to that consensus, patients might not understand the shared decision-making tool, and patients may refuse the early screening, increased provider time. D would be difficult to schedule with dietitian, insurance not pay for it, and then obviously the stakeholders would be all 7 providers at Lake Norman OB/GYN. Here's my references, and that's it.
Excellent.
I tried to get it within 5 minutes. Really had to move quick.
It looks like you slid in under the wire on that. Yeah, very good. That's a really interesting project. So when we get to the end, we'll have an opportunity to kind of talk through ramps, aims, that kind of thing for all the projects. But I think let's keep moving forward on each presentation right now. So who would like to go next? Elizabeth, do you want to test your sound really quickly?
Yes, can you hear me now?
Perfect.
Yay! Okay, do you want me to just go ahead and go?
That'd be great. Yeah, go ahead and introduce yourself, tell us where you're at, and then do your presentation.
Okay, so I'm Lizzie Brink. I'm based out of Tacoma, Washington, and I'm doing a project. It's essentially based upon, well, with the intention to increase maternal satisfaction with childbirth by focusing on comfort and coping measures in labor. So I'm guessing I just screen share over here. Okay. Okay, so hopefully this will, maybe we'll just, I wonder why that's not working. There we go. Okay, can you guys see my screen with this little road and the dots?
Yes.
Okay, oh goodness. Okay, perfect. So, like I said, I'm Lizzie Brink. Here's my project. It is entitled A Patient-Centered Approach to Increase Maternal Satisfaction in Childbirth by Promotion of Comfort and Coping. So my aim statement is to increase maternal satisfaction with childbirth to 90% of women, stating that they are very satisfied with childbirth by January of 2018. So the underlying problem is that maternal satisfaction with childbirth is an integral measurement of quality patient-centered perinatal care. And the HCAHPS survey closely ties childbirth satisfaction to reimbursement for many of our facilities. So it's a growing concern for all of us. In addition, promotion of comfort and coping in labor are fundamental measures affecting maternal satisfaction and long-term health and wellness. Our rationale here is that women want to have their preferences honored and their expectations met regarding modalities of comfort and coping in labor. So with my chart review and patient interviews, I found that women want additional modalities of pain care. They want more opportunities for movement in labor, and they want their preferences to be met. Additional outcomes with a greater emphasis on patient-centered care and a supportive comfort and coping in labor, some additional benefits are expected. So these include, but are not limited to, women feeling empowered and enriched in the process of shared decision-making. It's also positively impacting women's sense of self-confidence and will hopefully help to affect their self-confidence as women, as mothers, and throughout the rest of their lives. This will also unify the healthcare team and improve job satisfaction. In addition, this has the potential to set the organization apart and draw patients to choose this healthcare system due to the reputation of the care that we provide. So our measurements of change are, of course, organized by the 4 ramps. So our ramp A, staff engagement. Our outcome is to increase the confidence of staff to support physiologic birth and to promote comfort, coping in labor to 80%. Our process involves increasing the number of staff engaged in training to support physiologic birth. And our balancing measure will be that the RN staffing will not exceed the AWHONN staffing guidelines at any time. Our ramp B for patient engagement is to increase the number of patients who feel empowered with their options for pain care in labor to 90%. And our process is to increase the number of patients who have participated in shared decision-making regarding options for pain care in labor to 90%. And this would all happen in the process would happen in the prenatal care environment. Ramp C, increase the number of labor patients who achieve their preferred method of pain relief in labor to 90%. Our process will be to increase the number of patients who are assessed with the coping with labor algorithm to 90%. It's a really fantastic algorithm. And then ramp D, our outcome is to increase the appropriate use of intermittent auscultation to 85% of eligible patients. Our process is to increase the number of patients who are screened for eligibility with the intelligent intermittent auscultation algorithm to 85%. Moving on to our key points. So our stakeholders, our very key stakeholders include, many people that have touch points on this laboring woman. So our prenatal care providers, the perinatal nurse managers, and our bedside labor and delivery RNs. So moving on to our initial changes and barriers by RAMP. RAMP A, so our initial change will be a staff in service. So we will view and discuss these short informative videos regarding comfort and coping in labor. RAMP B, initial change will be a patient we'll be engaging the patient with a shared decision-making tool, writing a birth plan. And the barriers for this would be non-compliance with prenatal care providers. RAMP C, our initial change is to assess for coping versus not coping in labor, rather than asking the patient to rate their pain on the traditional 1 to 10 numeric pain scale. The barriers would be non-compliance by labor and delivery staff. And then RAMP D, initial changes to is on admission, complete a risk assessment for eligibility of intermittent auscultation in labor by use of a dot phrase. Barriers are non-compliance by labor and delivery staff, further compounded by understaffing. That is all. Here are all my references. And back to the front here. I will end the screen sharing if I can figure out how to do that.
Thanks, Lizzie. That sounds like a really interesting project.
Thanks. Okay. We're back now, right?
Yes. Yeah.
Okay. Yay.
All right. Who's up next? Deborah and Ryan, it looks like, okay, we could flip coins, but.
We're getting down to you don't have to make a choice here. Okay, pull this up. Okay, so as I said, I'm doing my project on emergency department throughput. My aim statement is that low acuity patients in the emergency department will have a door to disposition time of less than 90 minutes by the end of the year. The problem is that currently our wait times are horrendous. So for these low acuity patients, currently 130 minutes or more is what the average low acuity patient will wait in our emergency department. And clearly this can get better because our urgent care is also part of the hospital, and seeing the same level of acuity, their patients are getting out of there in less than 45 minutes. National average for this is about 90 minutes, okay? The reason? Well, for the most part, we have a good emergency department, but when you look at our metrics, one of the big problems that you're going to notice that's just going to pop out at you is the low acuity wait times. Nationally, this is a problem as well. There are increasing numbers of patients seen in our in emergency departments in general. Increasing numbers of low acuity patients are included in that. There's an increased wait time in the emergency department in general. And an increased wait time will increase the mortality of patients. So the benefits will be to improve the quality of care. We're going to be increasing the safety for the patients, hopefully increasing patient satisfaction along the way, and improve efficiency in the ER as a whole because of just less congestion. My measures for the teamwork ramp, what I want to do is utilize patient whiteboards. So frequently the RNs in the rooms are busy and they're not able to, I'm not able to talk to them because they're doing a procedure in another room or something. So we have existing whiteboards that I want to utilize. My measure will be increasing the level of communication between providers and RNs in the emergency department to 70% by the end of the year. And I can measure this with a survey that I've created and gotten baseline data for. My outcome will be increasing communications to 70% based on that survey. So for my patient engagement aspect of this, I want to provide the number or contact information for a local primary care provider that these patients can be established in care with. And since they're low acuity, they really don't need to be seen in the emergency department to begin with. And so we want them to receive care at the appropriate level. So my process measure for that is provide 90% of patients reporting a lack of a PCP with information. My outcome measure for that will be to decrease the number of low acuity patients seen in the ER by 5%. I think that's reasonable, just it's difficult to change behavior. So 5% I think is reasonable. My first process change is to increase adherence to room designation in the department. So currently we have these rooms, we call them our fast track rooms, and we have these low acuity patients are supposed to be seen there in those rooms, but frequently they're not. So my process measure is going to designate 4 existing rooms as fast track rooms, and the outcome for that will be to decrease the length of stay for these low acuity patients. The second process change is to initiate rapid strep tests in triage for patients meeting certain criteria, the Centaur criteria. And the reason for that is to get things started so that these patients can have timely workup. My balancing measures for all of these, I'm going to decrease, for the first ramp will be to decrease patients seen per day. So if this is working too well, we may just, and we're too congested, then we may not see very many people to begin with. Second balancing measure is to, if there are decreased numbers of PCPs actually accepting patients, maybe they're being inundated by a high number of patients. Higher acuity patients that begin to occupy the fast track room because of decreased number of higher acuity beds, secondary to congestion, could be an issue. And if finally for the strep test, if the lab is just completely overwhelmed by the number that we're sending, that would mean that we're overshot. The initial changes for teamwork, I'm going to have a kickoff meeting, discuss whiteboards, barriers to that. Staff is busy, you may forget. Patient engagement, going to provide the list of PCPs, barriers to that. I have to ask, I may forget as well. Process change 1, we need to initiate strep tests, barriers to that. Staff is busy in triage, there are different shifts. You've got to get the word out. And for the process change 2, I have increased adherence to room assignments. Staff has their habits, they may have trouble adhering to that if they've been doing something different. I have my list of stakeholders here, my project sponsor, my mentor, and Dr. Myers is my advisor. Here are my references. That's it.
All right, very nice. And Deborah.
Guess I'm next.
Yes.
So if all of a sudden I fall asleep during this, it's because I got 3 hours of sleep in the last 36. So
Oh my goodness.
I'm like working on staying focused here. All right, here we go. Oops. Okay, my project is improving timely diagnosis of perinatal depression in the office setting, implementation of ACOG screening for perinatal depression guidelines. And our aim here in our office is to maximize.
Deborah,
What?
we're not able to see your slides.
Oh, okay. Let's see.
There's a button on the far left, a green button that says
Yeah,
screen.
I hit that button. So
Oh.
hold on. Let me escape here.
Okay.
Yes, I did hit that button. So hold on. Let me try it again. It says I'm.
There's two buttons, Deborah. There's the screen
The
share
green
button,
one.
and then it says share.
Okay.
Share entire screen.
Share.
There you go.
Okay. All right, let's start this over again here. Okay. Can you see now?
Yes.
Okay. Improving timely diagnosis of perinatal depression screening in the office setting, and it's regarding implementation of ACOG's screening for perinatal depression guidelines. And our aim here at the office is to, at Lane Women's Health, is to maximize timely recognition of perinatal depression in our pregnant patients by increasing our antenatal and postnatal screening and also our education rates to 90%, and decreasing our postpartum visit no-show rates to 10% or less in the next 90 days. Depression or depressive episodes that occur during pregnancy or during the first 12 months postpartum affect as many as 12 to 20% of women during pregnancy, and left untreated, these can have devastating physical, psychological, and financial effects, not only for women and their infants, but also for their family and their community and society. When you consider that there's approximately about 4 million births per year in the United States, and if you utilize the more conservative estimate of 12% will develop perinatal depression, that would suggest that approximately there are about 480,000 cases of perinatal depression per year among these mothers. And Knapp and Parsonage in 2016 estimated that the lifetime cost of perinatal depression per woman is about over $95,000. And when you consider, when you multiply that times the 480,000 women, it indicates a lifetime cost of over $45 trillion just for these women alone in this 1 year. So my rationale is I audited obstetrical charts in our office, 21 to be exact, from our May 2017 vaginal and cesarean births. I audited them for perinatal depression education, screening, and for incidence of perinatal depression. And despite the ACOG recommendation that these patients should be screened at least once during the antepartum and once postpartum periods, there were no antenatal patients screened in our office at all for depression. However, it was a little bit better. The postpartum screening, we were at 86%, which was good. But then again, there was no perinatal depression education documented in any chart that I reviewed. And again, while 38% of our patients indicated a past history of depression or anxiety at their first appointment, only 5% or 1 out of 21 screened positive for postpartum depression. And what was concerning was that there was a postpartum visit no-show rate of 14.2%, 3 out of the 21. And it's concerning that these patients that no-showed all had reported history of postpartum depression in their first visit. Our short-term expectations would be that a standardization of care in the office, which would result in timely diagnosis of perinatal depression. Also improved team building and improved patient and staff satisfaction. And long-term, there would hopefully be decrease of maternal and infant complications, which would result in improved maternal and infant health, and also improved family and economic outcomes. And my measurements have changed. Team engagement, my intervention would be team education, and my process measurement would be at least 75% attendance for the meetings, and outcome would be 80% compliance with our postnatal, our perinatal depression checklist. Patient engagement, we would do a video on a stage-based interactive patient tool, and our process measurement would be at least 90% of our patients would be AJs, and that 80% would report increased knowledge of perinatal depression, and that would be our outcome measurement. Our process change A would be to universally screen all of our antepartum and postpartum women using the Edinburgh postnatal depression scale, and that at least 90% of eligible patients would be screened during these 90 days, and that our outcome measurement would be that we would have a greater than 5% positive perinatal depression screen over these 90 days. And my process change B would be a decrease in the postpartum visit no-show rate. Intervention would be a follow-up phone call at 4 weeks postpartum. 90% of our patients, postpartum patients, would receive hopefully the phone call at 4 weeks, and then at least 90% of our postpartum patients would show for their 6 weeks postpartum visit. Measure would be appointment wait time, because the concern would be that all this increased screening and education would increase our appointment time, and which would increase our office wait time, and would result in dissatisfaction of the providers and the patients. Our initial changes, I already discussed some of those, would include team educational meetings, universal perinatal depression screening during the antepartum, and we're already doing it at postpartum using the EPDS, and patient education using a perinatal depression video and an interactive patient handout. And we already discussed the follow-up calls to our patients at 4 weeks. And one good thing with that would allow us not only early assessment for postpartum depression symptoms, but also hopefully encourage our patients to attend their postpartum visit. Barriers to change would consist of resistance to change in the office, lack of time in a busy office setting, and disinterest in the project on the part of the providers and the patients. Key stakeholders would be our physicians, our office, our nurse practitioners and midwives, the nurses, and our office staff at Lane Women's Health, and also my project sponsor. And there's my references. Thank you. And just a note, you know, I realize I have to change some of these as far as you know, my outcome measures, because I'm kind of a literally thinking person. You know, in my mind, if you're educating, and maybe we can discuss this later, but if we're educating, then my outcome measure would be, do they really change their practice? But at our meeting last night, I guess that wasn't what I'm supposed to be doing. So anyway, maybe you guys can help me with that.
Yeah, definitely. Oh, I'm getting a little bit of an echo. Can you, let me see if I can mute you real quick and see if that will make a difference. Okay, great. Yes, my brain is not capable of talking when there's an echo. I'm not sure why. So I think it is really hard to wrap your minds around these process measures, outcome measures, how these things, how the processes lead to the outcomes, how the outcomes should all sort of dovetail together and lead to the aims, or to the aim. It takes a really long time. And by the end of this, it will all seem really obvious. By the end of, certainly by the end of your implementation, everyone is sort of like, yes, well, of course, we've always known this, like, that's obvious. It is hard, and I personally am struggling with how to make this seem really clear on the front end. And what I believe right now about it is just that it takes a lot of time to puzzle through. So we'll talk about it again, and you probably will have to talk about it many times and think about it many times before it all just sort of falls together for you. So don't want anyone to feel bad about it not seeming clear. It is actually perfectly normal for it to seem completely messy at this point. So what I'd love to do is talk through all of the different components that you guys all presented on. Talk through each thing and kind of see, we'll pull out one person at a time and see if somebody wants to, you know, talk about an aim statement, and then we'll talk about the components of a good aim statement. We won't be able to review everyone's aim statement, then everyone's measures, but what we could do is review one person's aim statement, and then all of you can kind of compare in your heads. Do I have those critical components? Do I have the for whom and the by when? All of that. For whom, by what? I'm having trouble with my prepositions here, but anyway. So that we would have all three components of that. So why don't we start with an aim statement? Does anyone have one that they feel really good about that they would just really like to share? Like, yes, I know my aim's awesome. I want to talk about it.
We can look at mine.
Okay, let's pull it up. So if you'll screen share with us and get to that slide where your aim statement is.
And if everybody just wants to keep your presentation on your desktop, because we will go back and forth and just have you keep pulling it up. So by the time we're done, you'll be really good at presenting.
Okay, great. So we have Brian's aim up here. Why don't you read it to us?
Okay, low acuity patients in the emergency department will have a door to disposition time of less than 90 minutes by 12/16/17.
Okay, so let's look at the critical component. Excuse me, components. Do we have the big answers? So is the statement clear? Is it easy to read? Do we understand what it's saying? So all of you guys, I know that we've just done these sort of formalish presentations, but now this is casual time. Now I just want you guys to talk and participate and kind of make this a little bit of a collaborative learning thing where we learn from each other. I know it's hard to switch gears quickly like this. But does everyone feel like that aim statement, does it seem clear? Is it easy for you guys to understand?
Yes. Mm-hmm.
Yeah, awesome. I think it does look clear. And then does it have the critical components that how good, by when, for whom, that kind of thing? So let's start one at a time. Does it say how good or how much? Does it have a measurement?
Less than 90 minutes.
Yeah, absolutely. Less than 90 minutes. So we know exactly what our goal is. We'll be able to tell if we met it, which is really important. And then does it say by when?
December 16th, 2000. Yeah, sorry.
Yeah. And then for whom? Is this for the whole hospital? You know, all those things.
Low acuity patients.
Yeah, and I really like that you narrowed that, Ryan, to low acuity patients. I like the way you said that. I think that's a really important component of a project like this, that we're going to focus in on something that we think we can actually change. And I think you're right. I think you can lower, especially because the time is fairly excessive right now. I think you've got a good chance of being able to make a real dent in that. Dr. Butler, do you have anything to add?
Just writing in there that I'm going to write this in there, Ryan, for you. Andrea Hughes is just finishing up, and she did a similar project in a psych ED.
Okay.
So I know that you all got the recording of when everybody, or the send out of everybody's recordings are, but you might want to specifically find out when hers is, because she did a similar type. It was a psych ED, but you might want to just watch that. She did a really nice job.
You said Andrea Hughes?
I'm typing it in the chat box.
Ah, okay.
Yeah, and I actually have her, I've got the schedule in front of me. That will be September 5th at 3 p.m. Eastern. But the recordings are available as well, although it takes just a little while for them to come up. Yeah, that would be a great one.
Very good. I liked it. I like the low acuity patients. Of course, I've got Andrea's on my brain. I think it's very good.
Thank you.
Quickly, do any of the rest of you have questions about your aim where you just think like, yeah, Ryan's is great, but I can't figure out how to make mine like that?
Remember that this is one of your touch points. This is not the time to be proud. This is the time to say, I have no idea what I'm doing.
I will put mine up.
Okay.
I will always put mine up. I just put needs work on that. So mine is increase early identification of patients with GDM, complicating pregnancy, and achieving right patient-centered care. So I have the by when, for whom, but I don't really have a for how good.
Coral, will you leave yours up for a second? There you go.
Sorry.
Yeah, so you're right, you don't really have a like increase to what?
Yeah.
She has 65% there.
Oh, you're right.
Oh, that's how good.
Well, so what do you mean by that exactly? When you say early identification, that means that you would want to. So I'm a little bit of a percents become important to me. I don't know why, but it is one of those things that that using them correctly is important to me. So so when I read this, I sort of think through the clarity of it, and I think, okay, well, you know, how would we know? So we're going to increase the early identification of patients with GDM by 65%. So there's the first thing I see here is a common mistake. I would say like 75% of all students do this. If you increase something by 65%, then what you're saying is that you would take the current rate, you would multiply it times 0.65, like you get what 65% of the current rate is, and then you would add that to, and so that's not really what you want to do, right? Because you don't really care. I mean, that's one of those gimmicks that they use to like make you think there's less cereal or less sugar in the cereal or something like that. It's, you know, it's not a real thing. So you could say, typically you can replace the by with 2 to say 265%, and it's just a real easy way to make that more accurate. In this case though, just as we think about it, let's make sure that we really understand. You'd want, what this is saying to me is that you are wanting to make sure you catch at least 65% of the cases of gestational diabetes, the early cases of I guess gestational diabetes in the first trimester.
And then implement that right care.
Okay. And I think
so adding those two together and then, you know, averaging.
So I think the right care and the 65% makes sense to me, because you can say of all the people who are identified with gestational diabetes early on, that all of those people received right, or that 65% of those people received right care. That makes sense to me. The only problem with identifying 65% of the people with early gestational diabetes is that you actually won't know about any of the cases you didn't identify.
Right.
So it will be hard to identify 65% of them, or to know whether you identified 65% of them. So I think what you're probably after there is something more along the lines of just focusing on the right care, because the right care is that all the patients are screened, right? So everyone gets that initial sort of screening questionnaire, or a provider is thinking through their case, asking questions. And then of all the people who qualified for the actual first trimester screen, that they received the 1 hour or whatever screening you're going to do. And then of the people who are positive, that they then received the necessary interventions.
Okay.
So that's, as you're working on rephrasing it, I would rephrase it in some way that what you're looking for is 65% of patients received right care related to gestational diabetes, something like that. Don't copy my words exactly, because you won't come up with the best ones on the fly like this.
Okay.
Debbie, tell us what, go back, Coral.
Oh, sorry.
Debbie, tell us what words she can get rid of in here. What words are unnecessary?
Let's see.
Patient-centered care.
No, you have to have an IOM aim, right?
That's
no,
right.
You don't have to have it in your, you actually don't have to have it in your aim statement.
Well, we're not trying to increase early identification of patients, right? We're just trying to
I'm trying to increase early identification just because we're not really identifying it at all in our practice.
well, I guess that what was confusing to me is, are you trying to increase your early identification 65% or increase your right patient-centered care by 65%?
I guess I was trying to, because that's part of both my processes. Well, actually, with the patient-centered, or with my patient care, my grant B, C, and D really all together are going to identify early, implement 1 hour, and then implement that right patient care. So I guess would be all encompassing, and then that would be an average of 65%.
What about getting rid of the complicating pregnancy?
Yeah.
You don't really need that.
Fine with me.
And let's just see, if you take out patient-centered care, let's cut it right down to its bones and see. Patient-centered care, take that out. Increase early identification of patients with GDM and appropriate care.
So I would say, as I'm reading it, I'm thinking that the early identification is part of the right care. And so I don't think that you don't have to take early identification out, but maybe say that you are, that you're achieving right care, that you are using early identification and treatment to achieve right care, or something along those lines.
Increasing early identification and appropriate treatment of patients, increasing early identification, increasing early GDM, increasing early identification and appropriate care.
Could you say your aim is to achieve right care in
Early identification.
patients with early identified GDM patients?
No,
Achieving
her
right
point,
care.
her point is to identify them early. They aren't already identified. So increase early identification of GDM and appropriate treatment.
I would say by achieving right care, maybe. Increase early identification and appropriate treatment of patients with GDM by providing right care.
I don't even know that you need appropriate treatment and right care. I was trying to.
Right, to just come down to one or the other.
You're just going to have to think about this, because the thing that I think we need to leave you with is, in scientific writing, your words are really important. So to or by is important. And just as Nisa said, are you increasing only 65% of the identification? So the reason we qualify for quality improvement is you're going to do this to everybody. Your hope is to raise the bar at least up to 65%. But you want increase early identification of GDM.
But you're not going to test everybody, right? You're just for the early glucose screening test, you're only doing that to patients that meet certain criteria.
That's
right.
Yeah, and so that is that right care or that early identification. So it can be confusing, but the initial screening is really the screening questions. Like, you are screening to find out who needs the screening. If that if that doesn't make it more confusing.
Yeah.
Increase identification of high-risk women for GDM. I don't know, but you're going to have to play with this.
Okay.
Yeah.
It'll work. It hasn't been quite tweaked yet. And I would do it with your colleagues, because then they're going to get OB and they're going to get what you're trying to do. But you do have to tweak this a little bit.
Okay.
Okay. So, but I think you're all now very aware of for whom, by when, how much. Raising the bar to something. Okay, good.
Okay, can we look at my, oops.
You're muted, Deborah.
I hit that, but it didn't. Can we look at mine? You guys can tell me if I've got too much in there, if I need to cut mine down.
Sure.
Okay. There we go. Share. Oops. Okay. There. Is there too much information in there?
Could you get rid of our aim? Just maximize.
I think you could also get rid of pregnant patients and perinatal depression.
Yeah.
Could you get rid of the, you know, the intent to decrease postpartum no-show rate? Because the point of doing that is to identify depression. So it's kind of
Right, but if they don't come their postpartum visit, then we can't identify them.
Nisa, you're muted.
Deborah, are you able to edit on the screen that you're on right now?
No, I'd have to go back and I'm on there.
Okay. Why don't you go in and take out the initial words that everyone was kind of mentioning.
I'd just say to maximize.
You just start with maximize.
Maximize timely recognition of perinatal depression in our patients. Yeah, that's kind of redundant. Increasing antenatal and postnatal screening and education rates to 90% and decreasing our postpartum visit no-show rate. Okay. Well, I guess if you increase your postnatal screening to 90%, that would count those people that didn't no-show, I guess.
Mm-hmm.
So one of the things is you have what's called a composite aim. You have two aims. So you have to look at it as two parts. So just leave the second half for now.
Okay.
For whom, by when, how much, right?
Right.
So by how much of each part. So the first part is that she wants to identify patients with perinatal depression. She wants to increase their screening for perinatal depression. And now perinatal covers antenatal and postnatal. So you're increasing your perinatal depression screening. That's one thing, to 90%. And you're decreasing your postpartum visit no-show rate to 10% or less in the next 90 days.
Okay, so
get rid of antenatal and postnatal. Actually get rid of the whole first sentence. Take the first line out. Maximize timely. Take that out.
what is it, to maximize timely recognition of perinatal depression?
Yep.
Okay.
Oh, don't cut that part out.
Let's see.
You don't want to cut out the perinatal depression.
Okay.
Okay.
Mm,
Just take it out for a minute. I know it's scary.
yeah, it is.
Now write increase perinatal depression screening increase perinatal depression screening and education rates. Okay, so I have a question for you first.
Mm-hmm.
Last night we talked about ramps that hang, right? But nothing finishes with them. So
We talked about what? I couldn't understand you.
we talked about ramps. Like, am I echoing?
Yes, maybe I should turn my sound off.
Is that better? Okay. We talked about you never just screen. You never just identify. So you're talking about screening and educating. If I'm a smoker and you tell me that smoking is bad for me, is it going to move me to that point of not smoking? It's important that I know, right? But we're looking to change behaviors. All of these projects are looking to change behaviors. So is educating me or anybody else on what perinatal depression is going to change, for the most part, my behavior? I'm depressed. You've told me now that I'm depressed and that this is what perinatal depression is.
Right, but I put that in there because it was one of the recommendations of the guidelines that they should all be educated they should be screened antepartum and postpartum. And all we're doing right now is postpartum.
So I'm
So-
fully there. I'm not saying you shouldn't. I'm just saying you need to screen and treat. You always screen and treat. You never just screen them. So screening and educating is getting a part of the way there, but it's not quite enough. So what we had said with, I think, Ryan's and maybe Coral's was screen and treat. Screen and appropriately treat. And appropriate treatment would include education. Nisa, am I crazy?
No, I agree. I do think, and Deborah, having had quite a few patients or students who have done these kinds of projects, postpartum or perinatal depression projects in the past, one of the things that has always become important is exactly what you're saying, that all patients need this education about postpartum depression or perinatal depression, right? But that is actually part of the treatment. That is part of the management of, you know, of these patients, is to do that education. So I like screen and treat at a minimum. I think screen, educate, and treat would be possible, but I think treat must be in there.
Mm-hmm. And my point was that exactly that. Thank you, Nisa. That was really helpful. You're not just going to screen it and educate them. You might screen and educate them and treat, but you're not going to just screen and educate them.
Okay, but the problem is I can't have the treating part in my ramp, because if I don't get enough people in, I'm not going to have any data. That's why I didn't do the treating part as part of my ramp.
So what is your baseline of postpartum depression patients?
What do you mean, what is my baseline?
So when you did your chart review and you decided that this was a problem, you had to screen and say, you had to audit the charts and you had to say, what is our baseline rate of postpartum depression? How many, if you screened 20 charts, how many of them had postpartum depression?
Only one, but we only screened for postpartum. We didn't screen for antepartum. And the thing was, so that we had a 38% rate of depression, people reporting depression on their new OB history. So they had a history of the depression, 38%. And then only one of these 21 people we picked up as a postpartum depression. But then, like I said, 3 of them that didn't even show up for their postpartum visit had depression. And this is what our physician in our office was, he was saying, these are the people that you worry about. You know, you don't worry, the people that come to the office, you can treat them and help them, but you worry about the people that don't come.
So
but
you're looking at maybe close to a 40% depression rate.
Right.
So I think I understand what you're worried about. So in a screening, brief intervention, and treatment in a model, often your brief intervention is just with the positive folks. So you're worried that you won't be able to do a shared decision-making or any kind of engagement tool with your Ramp B folks, and you won't treat them with your Ramp D. Is that what your concern is?
Right, because if I don't have enough people that show up.
Okay.
So what I was thinking.
Wait. So I think I know what you're getting at. So if you're saying, if I educate everybody, if I do an engagement tool or it's not really decision aid, but an engagement tool with all people to educate them on postpartum depression as my brief intervention, then I'm going to have enough. I'm going to screen everybody. That's going to be a big ramp. And I'm going to have this brief intervention for everybody because I'm going to be educating everybody. And then you will have 2 full ramps. Is that true?
Yes. And
wait. So we have A is your teamwork. You're going to have whoever you have in your team.
Right.
B, you're going to have a really full ramp because you're going to educate all women. Your intervention for your brief intervention in your SBIRT model is going to be to educate all women on depression.
Right.
And you're going to have to do something. It's going to have to be an engagement piece. Okay.
Right.
So your B ramp is going to be full. Your C ramp, you're going to screen everybody who walks in the door for depression. Right. You're going to decide, we're going to do a new OB, 28 weeks, postpartum. You're going to figure that out. So that ramp is going to be very full. It is completely okay for your D ramp then to only have the people who are positive. Even if that's sadly 1 person a week. I'm going to give you a trick here. So for all of you, think about this. If you are looking at one of the things that I think we all need to think about as NPs, CNMs, whatever we are, is preventive health. So if your brief intervention is to educate all women on perinatal depression so that they can decide, because you had one person who was depressed that they caught postpartum, but you had 38% say antenatally they were on meds or whatever they were on. So there's a fairly high rate there. You want to think about, how can I do preventive health with everybody so I can engage everyone in preventive health? And then the few that I catch, and it's probably going to be much more because you're going to be doing this antenatally, are going to be in my ramp D. And that way if one ramp is not very heavy, you're going to be okay. Does that make sense?
Mm-hmm.
So I want everybody to really hear that. It's really important that you think about, often in the SBIRT model, the intervention, the brief intervention, is for the positive. Those, if they have depression, then I'm going to do this thing with them. But you can also do something where you do that with everybody. And then those who do screen positive, maybe there's an extra step, or maybe they just get that extra step down in the D ramp. It's not like you're only going to do this little brief intervention with them. You may do more with them because you may be referring them right out. You might be calling behavioral health in. You might be treating them and bringing them back in 3 days, or, whatever you're going to do. But that way you boost up that B ramp, and you're doing what is near and dear to my heart, which is preventive health. Because if you have 38% who are somehow saying that they're depressed, but you never caught them, you're right, you do need to educate these folks, but you're educating as your brief intervention, and it's not going to be strictly educating. You're going to have to make that into some sort of engagement. And then
I have some ideas on that if you have a second, or when you're done.
Yeah. Does that make sense to everybody, though? Everybody needs to actually really think about their B ramp. Is it going to be so wimpy and skimpy? And that is a way that you'd make Dr. Butler so happy doing preventive health, but you'd also fill up that ramp. It makes it a little bit more of a challenge because you do have to be careful that you take care of your women who actually are diagnosed as depressed. But what about those women who, are just mildly depressed? They have risk factors, but they aren't technically depressed. We don't want to let those folks go.
So there is an algorithm out there that talks about how what to do with those scores. So I don't know if you're screening using an EPDS or what you're screening based on, but if you're using an EPDS, then there's an algorithm out there that talks about patients who score a 0 to 4 on an EPDS. What kind of education do they need about perinatal depression? Well, everyone requires some education, right? So what you're able to do then is have a form where you're able to show the patient what their score is and what that means. So you're able to say, hey, your score is a 3, and so you're very low risk for depression at this stage. However, antenatal depression or perinatal depression can happen to anyone, and here are the risk factors, and these are the things I want you to watch for. And these are the lifestyle interventions that you can use to try to prevent this kind of thing from happening. Get plenty of rest, drink water, blah, blah. If your score is between 4 and 12, you don't technically have depression at this time. However, you're at elevated risk. Let's start thinking now about lifestyle interventions that can really help you to set up your life so that you are decreasing your risk moving forward. Are there people in your life that can help you with this? Can you, whatever. But sort of empowering women to say, hey, yes, actually, I am going to need some help. And if my neighbor offers to make me dinner, I should say yes. Those kinds of things, when you're able to help them figure out, whatever. Here is a system for how I can get help.
Yeah, I had a video and a stage base, like you said, you scored here to here. Here are some ways you can prevent it, and you scored here to here, you're at moderate, and, that was on my plan for the B ramp.
Yeah, I think that kind of thing works very well because it does engage everyone, which you need to do, but it also allows you to really target that engagement to what matters to them. Not everybody needs the full court press on depression.
So that's great. That's a really great thing to bring up, because you all need to think about what you're doing, and is my ramp B going to have enough engagement, enough bodies in there?
So is it, will it be totally confusing if I'm really interested now in Deborah's ramp B. Do you think it would be confusing if we pulled up Deborah's ramp B and use this as our opportunity to talk about a B ramp? and then to A, C, and D, or should we
What
come
do you
back?
guys want to do? We have an hour left. We didn't go over the problem or the reason. Do you folks want to go over the problem or the reason, or do you want to skip right to the measures? Because this is your show.
Measures.
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 Done. I think B-Ramp, Deborah, you are on for B-Ramp.
Okay. Let's see. Here we go. Share. Oops. Okay. So hang on, let me get my, you guys hear me?
Yes.
Okay, good. Okay, there's my B-Ramp, patient engagement. And my process measurement was, I understood that process measurement as being received the intervention of all my patients. And then the outcome would be, I was going to have a little questionnaire at the bottom of the education after the video and ask, how many, do you have increased knowledge of perinatal depression? Do you have any further questions or whatever? Percentages, I don't know. Did you just pull them out of thin air or what?
That's a good question. Yeah, so it is your best educated guess. It's saying right now we don't do this at all. And implementing a process change is fairly challenging, especially something like this. I can see, like in a clinic setting, this would be challenging. It sounds like you're going to bring in a video, and the video maybe is going to be, is it a different video depending on what their results were, or?
No, it's the same video, and it's only 2 minutes, and it's a really powerful video. And I thought, while they're waiting for the provider, they can put them in the room watching the video after they've, taken the screening and watching the video, and then we can come in and talk to them. And I was planning on doing this like the 24 to 28 weeks.
Okay, so when you say stage-based interactive patient tool, oh, I'm sorry, I'm understanding now. So the video is one thing and the tool is a different thing.
You scored 0 to 9. You're
okay. Excellent. Yeah. So so when we think about this, 90%. I think 90% is a lofty goal, but your site better than I do. Your environment is. If you think that's something that you can meet, I think that's. I think these numbers are really hard. You're not necessarily pulling them out of thin air, but you do have to kind of make an educated guess. And honestly, you may not be right. It may be that you get to 60%, and that's really, the best you can do with implementing a brand new process in a busy office.
Generally, we think about if you're doing 0, in 8 weeks, if you got to 20-25%, that would be quite good. Now, you do know your office or who's going to be doing this. But I'm going to ask you one other question besides the percentages. So your process, your process is 90% of patients educated in 90 days. So if your process is to educate them, your process should have to do with your video and your tool. Because if you're going to, let's just go with this. This is why you need to have an operational definition. Does everybody know what I mean by operational definition?
Mm-hmm.
How, if you were going to do, I think of operation in surgery. If you were going to walk into surgery, you need to know exactly where you're going to do. So 90% of you don't have an operational definition. If you had to give me one right now, what would it be?
It would be the percentage of patients which receive the intervention over the number of total patients.
So the number of patients who receive the intervention over the total number of patients. And then if you were going to say, that's exactly right, and you just skunked me, because the other one that you have here is 80% reports increased knowledge. So what is that one going to be? What's that operational going to be?
It would be the number of patients that reported increased knowledge of all the patients that received the intervention.
And do you have a knowledge test that you're doing?
Well, I was thinking about just doing the little questionnaire at the bottom of the interactive tool. You know, I feel this,
right. So
you know,
had,
with a Likert scale type thing. Yeah, I understand. I don't understand. I'm kind of sort of understand.
So think about this. If your process is to, I would say your process is to increase the utilization of this video and your tool. That's your process.
Okay.
And then your measurement is the number of, I mean, somehow you're going to have to measure. I would put an actually on your little interactive tool, I would put a question. Did you watch the video? Yes, no, because that's going to measure it for you. And then I would have your interactive tool saying, you know, you scored, you know, if you scored 0 to 4, you are blah, blah, blah. I love Nisa's idea. Here are some stress relieving ideas or some things you can do at home. If you scored 5 to 9, these are other things. If you scored 10 and blah, blah, blah. And then your outcome is not just education, but what about if they choose to do 3 things? Okay, please circle 3 things that you're going to do. So your tool has 0 to 4, here's some things. Here, 5 to 9, here's some things. 7 to 10 or whatever, here's some things. And they have to circle 3 of them. And then your outcome is not just knowledge, because knowledge is nice, but you can go further than knowledge. They have chosen 3 things that they're going to do, sort of what's called self-management goals, that they're going to state. And what happens when we state something? What happens when I say, I'm going to meditate twice a day? I may only meditate once a week, but in my brain, I'm thinking, oh, I said I was going to do it twice a day. You know, it does. It's been shown that if we state our goals, if we write our goals down, we are a little closer. It nudges us a little closer to getting there. So I think that would be a lovely way for you to not just have education. We really are... You're educating them, but you're going beyond educating them. Does that make sense?
Yes.
Yeah, I love that you said to circle 3 of the things that are already there. I have not thought of that before, and I really love it because it is both really quick. Like, it's an easy thing and a quick thing for patients to do, to circle 3 things. You can see it on the piece of paper. Yes, they have circled 3 things. But I also really love that that it's something that it's sort of there, it's self-generated. I have in the past had people, like we've had students that have put a line, like where a patient will write their own goal or something. But that's putting a lot of pressure on patients, is putting them on the spot, and you honestly get a little bit lower compliance with it, because other providers are going to feel uncomfortable about standing there for 30 seconds watching this patient try to write up a goal. And we all know not all of our patients are so good at writing a sentence like that. So, you know, having those 3 things out there, you know, they've already got all these things to choose from. They can just circle. I think that's a great idea.
And I've had students do, working with kids, they actually have pictures. And you just circle the pictures. And so your outcome becomes, and was your aim, don't go back to it, but was your aim patient-centered? What is your IOM aim? What is your IOM word?
Timely recognition.
Huh. Okay. Well, this is patient-centered.
Okay.
Okay, so there's a ramp B. That's a great one. Who wants us to look at ramp C?
Can I make a little, like, just a random comment about ramp C? I see everyone writing process change, process intervention 1, process change 2, process intervention 2, that kind of thing. We refer to it that way. There's a reason that you use those words. It's because we refer to it that way all the time, because I don't know what your ramps are called. So I refer to it all the time as your process change 1 and your process change 2. But you do know what your ramps are called. You do know what your ramps are. So in general, when you're writing about them on things, if you will refer to them as your whatever it is,
screening
ramp.
Or checklist or whatever. So that happens to be, Nisa's being really nice, because I'll have a meltdown if I see it.
It's like if you use the percentages wrong for me. Like, I have a mini meltdown and then I get myself together, hopefully, before I talk to you about it.
Yeah. Okay, who wants us to look at C? Who haven't we looked at?
Lizzie.
Yeah, I
Lizzie,
could look
let's
at mine.
Yeah, let's look at your C.
Okay.
Thank you for sharing, Deborah.
So measurements, and then my C. And I also have like the actual like measurement chart, if that would be easier to look at rather than this presentation format.
No, this is good. So I have a question here that I just want to clarify. Even, you know, I'm curious to hear what you say, because I'm not asking this question because I know the answer. I'm actually just curious. So your process is to increase the number of patients who are assessed using the coping with labor algorithm. Do you feel like your process will lead to your outcome? Will using that algorithm lead to, sorry, it just went away, to increasing the number of labor patients who achieve their preferred pain relief methods?
Your question is, will my process lead to the outcome? Correct?
Yes.
Okay. Yes, I believe so, because this this coping with labor algorithm, I don't have it right in front of me right now, but it's you go through these branches, and you know, does a patient desire pharmacologic intervention? Do they desire non-pharmacologic? Try these things. Are these working? Is the patient coping? No, then go this direction. And so, no, I see what you're saying.
Yes. Okay. I have heard of this, but I have not ever looked at it myself.
Mm-hmm.
And so I just pulled it up. And I would agree. Yeah, I think you're right. Now that I see it, I think it probably could lead to your outcome.
Okay.
It's actually really cool now that I'm looking.
Isn't that fun? I really like it.
Yeah.
The other thing that I'm going to say to you, and I said it with the last person, make sure you operationalize. Remember what that means. That means exactly what am I going to do. So a numerator, denominator, an average score. Make sure you operationalize every single thing, because that is going to be the piece that if we got rid of all the words, and actually you can get rid of all the words, on your measurement worksheet, if you got rid of the words and just had what the operational definition was, that is going to help you. You need to look at every one and say, is it the same as any of the other ones? Because sometimes we think we're doing different things, but actually when we come to measuring it, we say, oh, you know what? That's exactly the same as this one. And you'll catch yourself what I call double dipping. So your C is the number of labor patients who are assessed with the algorithm, or i.e. the number of algorithms used over the total number of laboring patients. So it's always the part over the whole. And then your outcome is the number of labor patients who achieve their preferred method of pain relief over the total number of laboring patients who use the algorithm.
Yes. Yeah.
So it's not going to work if they haven't used the algorithm. And I would say admission risk assessment. I was almost going to say that's like a screening ramp, Nisa, right? I mean, you're screening them for, or algorithm use, something. But yeah, takeoff process, because you need to actually be able to say, whenever you're talking about your project, you need to be able to say, yeah, it's about team engagement, patient engagement, using this algorithm, and such and such. You need to be able to whip those off in 2 seconds, because if that's so clear, crystal clear in your brain, what that C ramp is and what that D ramp is, it is going to save you hours and hours and hours of that
heartache.
Yes.
That too. And is there anything, so on the algorithm, you said it does lead us to using what they want for pain relief? That would be my only question.
You know, actually,
coping, not coping, coping.
Let's see if I can just like pull it.
No, I think you're right. It says, because it says patient desires pharmacological intervention, and then there's 3 choices there. Patient
Yes, you're
desires
right.
non-pharmacological, and there's all sorts of choices there. And then reassess. Where does reassess take you? I think that's quite lovely.
Mhm.
I think I want one.
I know. It is the best and worst thing about working in this program that every single, like, I'm like, well, okay, then we can implement that.
Yeah, that's a great one.
Hmm.
All right, so the only thing I would say to you is, and you've got them operationalized, I think that works. So your process, go back to your process again. C, increase the number of labor. So it's really implement the coping with labor algorithm,
Mhm.
right? Same
Yes.
difference. Number of patients who are assessed with the number of algorithms used over the total number of patients. Okay, I think, unless I'm missing something, Nisa, I think that looks pretty good.
No, I like it. I think it looks good.
Thank you all.
Okay, who wants us to look at D?
I have a can I ask a question about Elizabeth's? Have we looked at A yet on anybody's? Are we going to look at A if we do it? If we're going to, I'll wait until then. But
Yeah, I think we'll look at A at the very end. So it's, we have these in this, order. Obviously, everyone A, B, C, D, it makes sense to start with A. But the way these projects have kind of evolved over time, I think the C and D ramps are actually the first thing to be developed most of the time. And then you kind of figure out, like, how do you really engage patients with this project? And then ultimately, how do you pull your staff in and get them engaged? And staff engagement is actually my favorite ramp. It is the hardest, I think, and the most important, and the one that sort of makes or breaks the project more often than not. So yes, we'll definitely put some time into A ramp, but I don't like to do it first if we can avoid it. So one more of our process ramps. Anybody want to share their D ramp? I know, since there's only 4 of you, it's kind of you're all on the spot all the time.
I had 4 the other night also. It was actually really nice because everybody got to leave with one ramp feeling pretty good about. Who have we not done a ramp?
We can do mine if you want.
Coral. And Ryan, have we done one of yours?
Looked at my aim.
Oh, your aim. Okay, but we haven't done one of your ramps. Okay.
You want me to do mine, or Ryan, do you want to? It's up to you. I don't care. Either way.
Go for it, Coral.
Coral, have we already looked at one of your ramps?
Not yet. That was my aim.
Okay. Well, honestly, we've still got balancing measures. We've still got plenty to do. So whichever, one of you pick, and we'll.
So here's my ramp for D. Creating that logbook and then referring to a dietitian treatment with focus on right care. Outcome would increase mean right score by 80% before December 15th, 2017 by implementing referral and treatment and obtaining right care. And I have several documents with my charter that are in different stages.
Talk to us about your operational definition.
So operational definition would be let's see, this is okay, so this would be my mean score of identifying certain measurements, right care. I have probably another one that's probably a little bit better. No, this is. Hold on, I've got it in different, I guess it's different stages. So this would be, and then I would implement, so basically the number of those patients, high-risk patients in the logbook versus the total number of high-risk patients. And then the operational definition would be the mean score of identifying certain measurements like the right care mean score of right care provided. So anyways, there's a lot going on.
Your high-risk people came from your C-RAMP, right?
Right.
So you have a high-risk people, and then you need to, whoop.
Sorry. My computer has a mind of its own.
So you have your high-risk people that came right down into her D-RAMP, which is what they often do. You don't want to leave anybody dangling. You don't want to identify anybody as high risk and leave them out there high and dry.
Right.
And then she's implementing a 3-hour glucose if the abnormal, oh, so wait. So she's putting their high risk in the logbook. And then in the logbook, they're going to get all of the things they need. That's what her D is. They're going to get their 3 hours or their 1 hours or their dietitian or their whatever, their medications or glucometer or whatever it is that they need. So the question becomes, if they go into the logbook, which has all those columns that are blank, will that increase the amount of women who get right care? And she's listed out, well, she started to list all the things that they need.
Right. Which is the right care. So I tried to make it like 5 interventions.
So that's a question for you all. If she puts these people in the logbook, so all her high-risk people get put down into a logbook, is that going to support them getting the right care that they need? So she's implementing a tool.
Anyone?
Well, the logbook itself, that's just helping to focus.
It's a tool.
It's a tool, not the process.
So do you need to say identify instead of, because that's the point of the logbook, right?
The point of the I'm gonna turn up the volume a little bit. The point of the logbook would be to we'll keep track of the high-risk patients so that I can measure them with a mean score and then make sure that all of those measurements are met with the right care.
So maybe it's helpful to know that she's going to have a patient's name, their medical record number. She's going to have what they got on their 1-hour glucose score. So if they got a score that means they need more treatment, then she's going to have another column that has the 3-hour glucose test, which is next. And then it's going to have dietitian, and then it's going to have glucometer and all those things. So what it will do is she'll be able to say, okay, this person scored a 85 on her glucose test. So all those other things will be not applicable. They don't need those. This person scored 147. So she needs a 3-hour glucose test. But then she can have a column for the results of the glucose test. The 3-hour, if those are all normal, then she can put NA all the way across because they don't need it. So that tool is helping her, just like any tool, is helping her to finish those people off, to tie up that loop.
Well, and also preventative care. So if they have any type of risk factors to begin with, then, we can still talk about diet and exercise and lifestyle modifications to prevent, maybe at 28 weeks, they might be abnormal. So.
Does that make sense to everybody? Because you guys look really confused. Do you guys understand what right care is? Because I think a couple of you have a right care, don't you? Right care is when you make a bundle and you say they need like these 3 things or 5 things, and you get to decide what those are. In this, she's not looking at right care for her whole project. She's looking at right care for just this one piece. And then, Coral, do you have a right care for your AIM? I think you do, right?
I have it. No, not necessary. Should I?
What is your aim?
Well, I've been working on it. But identifying.
Yes, you do. So this is a right care.
Yes.
So you're going to have all those things down below, but you're also going to have, did they get the early screening, the early identification? So it's going to incorporate D's right care with the answer for probably C.
Right.
So you do have a right care aim.
Mm-hmm. Yes.
Nisa, thoughts, comments?
This one kind of took me a minute to work through, especially the outcome measure. It took me a minute to kind of think of this, but what I think I'm understanding from the outcome measure here is that you've got your 5 things, your 5 components of right care, and so the patients are going to receive a score based on how many of those things were completed. They got 3 out of 5, 4 out of 5, whatever.
Right.
And so then you're just going to have that. That'll just be tracked over time, like a mean score for those patients. So yeah, I think that works. And I like mean scores a lot. I think they are really easy to understand on a run chart.
Mm-hmm.
Where sometimes run charts can get, if your operational definitions get too complicated, then your run chart might be pretty. You might see a line going nicely up, but no one quite understands what that indicates. All right, I think that sounds really good. So now on to staff engagement. And I think, Deborah, you wanted to talk about yours, right? Oh, you're muted.
Okay. Well, I had a question about Coral because mine, and I'll put mine up, but let's see. Whoops. Oh, I accidentally closed mine here. Oh, well, it'll take me a minute to find it. Oh, wait a minute. There it goes. Hold on. There. Engagement. See my measurement, because they say I'm kind of skipping something here that I shouldn't go to just, the education. I can't assume that the education is going to cause compliance. But I was interested in Elizabeth's ARAMP, where she talks about increasing the confidence of the staff to care for these patients in labor. And I was wondering what measurement tool she was going to use.
Probably just like a simple like post-intervention survey, not a formal tool.
Oh, okay.
So you're just going to ask them if they feel more confident caring for these women.
Right.
Yeah. Oh, Judy, you're muted.
I guess the problem I have is, okay, team engagement, we're going to educate them. I look at it as like telling my kids they have to clean their room. And then I tell them my expectations and they have to clean their room by Saturday. And the outcome measurement would be, did they clean their room by Saturday, or they're not going to the party at night? But from what I'm hearing here, it should be increase their confidence in cleaning their room.
So Deborah, I will tell you, this was, I've been doing process improvement and quality improvement for a long time, and this was the hardest thing for me to learn. Like, this is why I love this ramp so much, why I love team engagement ramps so much, because I thought that if you told people that something was better, that a new intervention was better, then all the people would say, awesome, let's do it. And it turns out that's not true. They don't. You are asking them, I would say all of you, without exception, are asking them to do something that is different and probably more work than what they already do. You're asking them to do more work for no extra money and no real reward that you have to offer. So you need to engage them on some level. Like, you've got to convince them that they should change their behavior. And how or why would they actually do this for you? And what a lot of students, I think, the lowest common denominator here is kind of this like, but you're my friend and you like me and please do it because I'm getting a grade on this project. And I will tell you, do not go there if you can avoid it. That will buy you, like, maybe they will come to one meeting because they like you. That is it. Like, unless they are your very best friend, you're not getting true engagement out of please do it because I need you to. So you have to engage them on some other level. Somewhere deep inside all of us, and hopefully inside all the people you work with, is a clinician who wants to do a really good job, is a nurse, an MA, a receptionist, somebody who wants to do a good job. And so if you can find some way to engage them that really works for them, and it may take a lot. So it's going to be all the things. So you're going to educate them, and then you're going to motivate in any way that you can. So whether that's confidence, because I think confidence is a great one for labor management, because managing people who are hurting is scary. And people, if you don't feel like you know how to do it, then you just won't do it, and you'll just spend your time at the desk instead. So I think for labor, that one's perfect. That one can work though for a lot of different things. You can improve confidence. So you pick something that you think, you know, maybe it's just straight up engagement. Like, you are actually going to measure their engagement with the project. Are they motivated? Are they interested? Are they doing it? Are they excited? I think there are lots and lots of things, and you may have to change this. You won't change your measures, but you'll change what you're doing throughout the project. So your first intervention, that team education, that's perfect. I mean, you're going to have to do a kickoff meeting that sort of gets everybody, you know, that you have to straight up tell everybody what the project is, or they will not be able to do it, right, if you don't tell them. But you also have to kind of make them excited about it. So there are some good examples of things that students have done in the past.
Did you guys just lose Nisa?
Oh, we lost somebody.
Okay. So the other thing that you can do, which I don't suggest, and this is what Dr. Jolles was saying last night, is you could have two outcomes. Because increasing engagement, there are all sorts of tools that measure team engagement already done. And then you could morph them to kind of focus on perinatal depression. But we lost you, Nisa.
Yes, I saw. That's okay. Go on.
Go ahead. No, go ahead.
Yes. I was thinking about a student of mine who really needed to engage people in postpartum hemorrhage. So I think I lost you guys again.
No, we can hear you.
Oh, good. Okay. So when they walked into their education meeting for the first time, she had bowls of strawberry jello mixed with jelly, mixed with cornstarch, you know, bowls of blood clots. And so it's attention getting, right? You walk in and you're like, whoa, what is this? And they have to try to figure out how much blood they think is in each one. And then every time she met with them from that point, or every week or two, was something exciting and different and interesting. Or I had another student who had the people in her staff, it was an office staff in that case, they had to role play this conversation with clients so that they could kind of practice the use of the shared decision making tool. Or creating a simulation. You can get really creative with this ramp. You don't have to just pick one thing and, you know, we're going to meet all the way through, or we're going to do huddles all the way through. Those things work great, but I think it works even better if you get creative and really just think outside the box. What's going to get people's attention? What might motivate them to really do this thing?
The other thing we talked about last night was envision the best. Envision your best team. Like, if you walked in the door, use your 5 senses. You walk in the door to your office and you're talking about perinatal depression. You walk in the door to your office. What do you see? What do you hear? You know, what do you feel? Obviously not touchy feel, but emotionally, what do you feel in that office? Do you feel compassion? Do you feel burnout? You know, because if you ask yourself those questions, do we have any posters up on perinatal depression? Is there anything in the break room? You know, are people talking? I want people talking about perinatal depression. I want to hear the MA say, did you know? I want her to be fired up by what, that's what you want. You want a team who is, man, they're on it. They're thinking about it. They're excited about it. They want to make it better. They're motivated. Getting them there is really, really hard. But this is where you put on your fun cap and you think, okay, you know, it is not easy for some people. You know, I'm a very touchy person, but it's not easy for everybody to talk about perinatal depression. Like, what if they're actually depressed? Then what am I going to do? You know, is that an issue in your team? Do they need more comfort, if you will, or knowledge with the medications? You know, do they need a set standardized algorithm so they can walk in the door and be like, I don't have to worry about this because, man, she's got it all spelled out for me. So what is it about your team? You have to think about, if you just think of it from the educational side, and I mean from our side, not the education, like, we're trying to come up with an outcome for you, but think about, what does your team do? What is their problem? Why aren't they going there? Is it that they don't know that it's so prevalent? Is it that they don't want to deal with people who are depressed? Because most of us, like Nisa said, as healthcare providers, want to do a really good job. Like, we want to feel like we've made a difference in your life. So if it's hard to get appointments, if it's hard to get medications, your patients are very low socioeconomic status. I mean, you have to do those things so that they can feel like they're doing a good job. So what is it that they need? What is your team lacking?
Deborah, depending on your team, depending on how close you guys are and how much there might be friendships or relationships in there already, for when I wanted to engage my office in really thinking about perinatal depression, we did a movie night. We brought, you know, pillows and stuff. We used the waiting room of the office, and we you know, brought wine and popcorn, and we watched a documentary on postpartum depression that was really, really powerful. Everyone in our office, from secretaries on, like, was moved by the movie. What I think you have to be able to get people there, though, and not every office is going to have people who want to come in for 2 hours on an evening and watch a movie. But if you have that kind of office, something like that might be really powerful. Or find a 30-minute long something and show it at lunch one day and bring food for them. Or,
all right. But you've got to think about what you want from them. What is their lack? What is their problem? It's not just that they're not doing something. What is the deeper lack that your team is missing? So I'm just going to leave you with this very short story. My mother once, when I was, I don't know, probably 15 years old, she said, this is a mother of 5 children. She said, well, I'm going to work with these unwed mothers. And my sister and I both jumped up and we said, no. And she looked at us like we were crazy. And we both simultaneously said, no, you're going to tell them what to do to fix their life. And the problem is, you think that they're actually going to do it. They're not going to do it. We do it. Somehow you magically made your children do this, but it's not the norm, you know? So again, just what Nisa said, we think that if I use the smoking cessation, you know, if we teach them that why smoking is bad, then they're just going to stop smoking. But it's harder to change behaviors. It's really hard. Even if they really believe you, it's harder to change behaviors. So you've got to get more than that from your team. I know it's hard, but it can be really, really fun. Lisa's given you a little taste of the fun things you can do. That can be really fun. And I will also leave you with this. Not that I'm leaving you, but if you are, okay, this is what I need you to do. And it's a good thing to do this, so come on. Or if you walk in and say, hey, postpartum depression is hitting 40% of our patients, and we treated 1 person. So this is what, you know, I've looked up these things. Here's 3 or 4 choices. What do you guys think we want to start with? Let's start with this. Great. Give me 2 and we'll start with one of them. You come in full of energy, positivity. We can make a difference here. That is going to make a huge difference. And I also want you all to remember, you are implementing evidence-based practice. If you know that it's evidence-based practice, you can stand firm that this is the right, this isn't like, I think that we should do this. You can stand firm and say, this is what we need to do. This is shown in the evidence. You guys have read, you're the experts in this area. You've read so much on that one particular area. So you know this needs to happen, and you need to present it in that way, that this is the way we need to treat our patients. This is the way we practice care now. So I'm going to do this depression screening with you because this is best evidence, and I want to give you the best evidence. That's the way you present it to your patients, to your team, and they're your team. Don't call them, don't write anywhere that it's their staff. This is your team. You are a team. I'm going to be quiet now. Except that I think we lost Nisa again. All right. We have done, I do want to say that you only need, you can have as many as you want, but we did go over this last night. You only need one balancing measure. We had you make some for all the different ones, the different ramps, so that you could think about things. You need one balancing measure. And I think that I've stolen this from Nisa now. What she says is, what are people going to complain about the most? That is how you think about what your balancing measure is. Are they going to be worried that all your babies are going to end up in NICU, or you're going to have more C-sections, or Ryan, that you're going to triple our time, or, you know, whatever it is. We lost you, Nisa.
Yes, I'm glad the room still stayed open. I wasn't sure.
I know, I wasn't either. So that's measurements. Make sure you operationalize all of them very soon so that you can start looking at them and knowing how you're going to do that. The only thing I'd like to say about your initial changes and your barriers are, think about initial changes and barriers for A through D. What are my changes? What am I going to walk in on Monday and do for my team? And what is the barrier that I anticipate, so that you also, the unwritten there is, what is my solution if that barrier comes up? What is my plan B? And yeah, initial changes, barriers. I think that's all of the wild wisdom that I have for you.
Do we want to talk balancing real quick, or?
I just said they had to have, I gave them your famous quote. Okay. We have all stolen your quote, just so you know. All of us. We've all taken it.
That's funny.
Yeah. So do you guys have questions now? There's 12 minutes left. Let's just leave it for open. What questions do you have? What can we help you with? Ryan, you've been kind of quiet over there hiding.
I know. You know, when you try to listen actively, sometimes it's difficult to come up with things to say.
That's okay. That's okay. I just wanted to make sure you had the chance if you have something.
It's all been very helpful.
Do you guys have anything left? Anything else you want to ask us?
I know this all seems really scary and stressful right now. Stop for a second and just like recognize how really cool this is. I mean, this is a really neat opportunity. You are developing a project and you're going to implement it, and you get to pick anything in the world and do whatever it is that you think needs to be done in your site. How many times have you walked around thinking, oh my gosh, this is insane, this needs to be fixed?
And the thing is, you will make change. You really will make change. We have to bite small, but you will definitely, and it's amazing the change that you'll make actually in 8 weeks. It will not all be small. Most of you will make some significant change. And remember, one of the biggest changes that you want to make is introducing quality improvement or encouraging quality improvement if they already know what it is, and changing it from blame to improvement. For all of us, that's really a huge area that we need to move towards. I don't think I have any more words of wisdom. Actually, I think my brain is turning to mush.
All right. Well, I have enjoyed this session with all of you. I hope it's been helpful. I guess reach out if you need anything. Otherwise,
have a great night, everybody. Thank you so much for joining.
Thank you.
Thank you.
Bye-bye.
Good luck on your